about how to identify and treat anterior glide medial rotation syndrome of the humerus and scapula interrotation with insufficient upper rotation of the scapula. And this is my wife, Dr. Sergio Martinez, and she's going to be helping me translate in Spanish.
Hola, buenos días, doctora Rocío Martínez aquí. Voy a ayudar a traducir la presentación en español para el doctor Martínez. Hoy vamos a hablar de cómo identificar y tratar el síndrome de rotación media y el deslizamiento anterior del húmero, la rotación interna escapular con rotación ascendente insuficiente.
All right, so just to talk a little bit about me, I was born and raised in Brownsville, Texas. I graduated from the University of Texas at Brownsville, now called UTRGV, in 2011 with the Bachelor of Science in Exercise Science. I then graduated from the University of Incarnate Word in 2015 with the clinical doctorate in physical therapy. After that, I completed a 3-year residency and a 1-year fellowship through the Manual Therapy Institute in 2018. I then completed a full certification dry needling, level 1 and 2, through Optimal Dry Needling Solutions in 2018. I'm a certified clinical instructor through the American Physical Therapy Association. I'm currently seeking to become a board certified orthopedic and sports clinical specialist. I married my middle school sweetheart here, and I'm a father of 2 boys, Mateo and Mason, who are 3 and 1. And I'm also the founder and a co-owner with my wife, 2 outpatient orthopedics that we started in 2019 in the South Texas area.
Ok, sobre el doctor Martínez, fue nacido y criado aquí en Brownsville, Texas, graduado de la Universidad de Texas en Brownsville, ahora está UTRGV, en 2011 con la licenciatura en Ciencias de Ejercicio.
Sorry, can you unmute yourself? I'm sorry, I have to mute everybody. I'm sorry, yeah, thank you.
Ok, graduado de la Universidad de Incarnate Word en 2015 con un doctorado clínico en fisioterapia. Completó una residencia de 3 años y una asociación de 1 año a través del Manual Therapy Institute en 2018 y completó una certificación completa en punción seca de los niveles 1 y 2 a través del Optimal Dry Needling Solution en 2018. Es instructor clínico certificado por APTA en 2019. Actualmente está entrenando para el título de especialista clínico ortopédico y deportivo. Estamos casados. Él es papá de 2 niños, nuestros hijos Mateo y Mason, de 3 y 1 año. Y es el creador y dueño de 2 clínicas ortopédicas de fisioterapia, Cert Mobile Physical Therapy, desde 2019 aquí en el área del sur de Texas.
Okay, gracias. Okay, so I want to talk about what are movement impairment syndromes. So movement impairment syndromes were developed by Shirley Sahrmann and her colleagues. They developed a kinesiopathological model, which was developed to explain the occurrence of these impairment syndromes by using clinical tests to identify the impaired movement within the kinetic chain and then optimize interventions that are specific to the particular dysfunction. So in the impairment syndromes, we usually see sustained postures and repetitive movements that are believed to be the risk factors for impairments in the movement system. There are intrinsic and extrinsic factors that can be causing the tissue changes. So with these movement impairment syndromes, with this model as well, we're able to find corrections to the impaired alignments and movement contributing to the tissue dysfunction through addressing the stiffness, weakness, and the poor neuromuscular activation patterns in the proposed treatment.
Entonces, ¿qué son los síndromes de deterioro de movimiento? El síndrome de deterioro de movimiento MIS fue desarrollado por Shirley Sahrmann y colegas. El modelo kinesiopatológico KPM se desarrolló para explicar la aparición de MIS. Se cree que la postura sostenida y el movimiento repetitivo son factores de riesgo de deficiencias en el sistema de movimiento. de cambios en los tejidos. La combinación de microinstabilidad, rigidez relativa, el patrón de la activación neuromuscular y el aprendizaje motor contribuyen al desarrollo y persistencia de la deficiencia. El tratamiento propuesto para el MSI es la corrección de las alineaciones dañadas y el movimiento deteriorado que contribuyen a la disfunción del tejido mediante el tratamiento de la rigidez, la debilidad de los patrones de activación neuromuscular que el paciente presenta. El QPM utiliza pruebas clínicas para identificar el movimiento deteriorado dentro de la cadena cinética y optimiza las intervenciones que son específicas para esa disfunción.
Okay. So I want to talk about the arthrokinetics of the shoulder. So we have close pack and open pack position. In the close pack position, it's abduction and external rotation. And usually these are painful motions for patients with shoulder dysfunctions, such as like shoulder impingements, rotator cuff tears, or tendinopathy. And so usually these two positions are very painful because it's a closed pack position, puts a lot of compression in that joint. The open pack position is very important because this is how we want patients to be in when we're doing our mobilization techniques. So you want to make sure the patient has 55 degrees of abduction and then 30 degrees of horizontal adduction when doing these mobilizations. And in the capsular pattern, it's very important to know these, just because if a patient is demonstrating poor motion with these movements, then that could be a possibility of a frozen shoulder. So external rotation, abduction, internal rotation is the capsular pattern.
La artrocinemática del hombro, la posición del paquete cerrado, es abducción y rotación externa. La posición de paquete abierto son 55 grados de abducción y 30 grados de abducción horizontal. El patrón capsular es rotación externa, abducción y rotación interna. La posición de paquete abierto es la posición en la que deben posicionar los pacientes al realizar técnicas de movilización para que sea más a gusto.
Okay, so in this video, I'm going to show you how I like to measure normal scapular alignment. And we're about to look at this video right here.
Ok, vamos a ver en este video la alineación escapular normal. Ok, va a explicar en el video el borde medial de la escápula debe estar a 3 pulgadas de la apófisis espinosa torácica y debe estar la escapular situada entre la segunda y la séptima vértebra torácica y el ángulo superior debe estar alineado con la segunda apófisis espinosa torácica.
Okay, so I'm going to go ahead and show you how I measure the alignment of the scapula. Okay, so I want to make sure is find the bony landmarks of the spine of the scapula here. Go a little bit superior to that. You should find the superior border. Okay, go along down the line here, and you should find the inferior border. Okay, and that medial border side here, that should be 3 inches away from that spinous process. So I do my measuring tape, and lo and behold, he's 3 inches away, which is good. And you want to make sure that the superior border is in line with the second thoracic vertebrae. So I'll put my hand here, feel for that C6 to disappear with extension. Then I go a little bit lower, and that's C7, T1, and T2. So I'll put T2 here. The other way to confirm that is to kind of wrap around and find the rib that's associated with that, and have them take a deep breath. And if I feel that rib kick up, I also know that's on the second thoracic vertebrae. And as you can see here, the superior border is lower than that T2, so that lets me know that this scapula is depressed. And you want to make sure that the scapula is situated between the second and the seventh thoracic vertebrae. All right, so on this video, we're going to be showing you how normal humeral alignment should be. There are many ways to identify it, but I feel like this is the most beneficial for therapists to use in the clinical setting.
Ok, en este video vamos a ver la alineación humeral normal presentada por el terapeuta. El humeral no debe sobresalir más de 1/3 de la cabeza humeral por delante del acromion.
So we're going to measure the anterior glide by palpating along the clavicle to get to the anterior acromion, and then going back to the posterior acromion. You do 2 lines to distinguish the thirds of each section, and then you look for the humeral head, and you want to make sure that that humeral head is in that 2/3, not anterior to that. So we're all right. So with scapular internal rotation with insufficient rotation, there are a lot of signs and symptoms to this. So one of them would be cerase anterior weakness. They may have pain in the area of the rhomboids. It's one of the major causes of the glenohumeral joint impingement. And people that are vulnerable to this are new mothers, string instrument musicians, weightlifters, waitresses, or any jobs that require to be sustained in flexion, or if they sit with keyboard or armrests too low. Their scapula is downwardly rotated during arm rotation or when load is placed on the arm. If you see that medial border of the scapula is less than 3 inches from the spinous process, if you see that that scapula is depressed, or if you see if the scapula is downwardly rotated, you can also see if the inferior angle does not reach mid-axillary line with full arm elevation, and if passively performed up rotation alleviates their symptoms. So those are key tests to identify that dysfunction.
Ok, entonces, ¿cómo se presenta este paciente con rotación interna escapular, con rotación ascendente y suficiente, debilidad del serrato anterior? Puede tener dolor en el área de los rhomboides. La principal causa de pinzamiento de la articulación glenohumeral. Personas que pueden ser vulnerables a esto son mamás nuevas, músicos de instrumentos de cuerda, levantadores de pesas, trabajadores pesados, camareras, trabajos que requieren que el brazo se mantenga en flexión, sentarse con el teclado del reposabrazos demasiado bajo. La escápula gira hacia abajo durante la rotación del brazo o cuando se coloca cargo en el brazo. El borde medio de la escápula está menos de 3 pulgadas de la apófisis espinosa torácica. La escápula puede estar deprimida hacia abajo. La escápula puede estar rotada hacia abajo. El ángulo inferior no alcanza la línea axilar media con la elevación completa del brazo. Y la rotación ascendente pasiva alivia los síntomas.
And so everything that we just talked about will be showing in video shortly, but we just kind of wanted to give you a rundown so far. So on this figure here, we can kind of see the movements of the scapula. So in figure A, you can see how the upper rotation and the downward rotation would look like. In figure B, you can see how the external and internal rotation looks like. It's almost like internal rotation is like supinating if you're looking at it from posterior. And then you can also see how the scapula can anterior tilt and posterior tilt.
Ok, en esta foto aquí vamos a presentar los movimientos de la escápula. Entonces, viendo desde atrás a alguien, la letra A enseña rotación inferior y rotación ascendente. La letra B enseña a alguien viendo desde arriba hacia abajo, rotación externa, rotación interna. La letra C enseña a alguien del lado, inclinación posterior, inclinación anterior de la escápula.
Okay, so this is one of the videos I wanted to show you that if when you manually upwardly rotate the scapula when your patient lifts the arm, if this alleviates their pain, you have your diagnosis.
Ok, en este video vamos a enseñar una prueba clave que el terapeuta gira manualmente hacia arriba la escápula cuando el paciente levanta el brazo. Si esto alivia el dolor, puede confirmar tu diagnóstico.
Okay, so this next test that we can do for someone that we suspect has an insufficient upper rotation is to assist their scapula into upper rotation to see if that will help decrease their pain and improve their motion. So let's say a patient was only able to lift their arm just up to here. I would tell them, okay, relax. and then tell them, okay, do it again, and assist that scapula. If I see that there's an increase in range of motion and a decrease in pain, then that's another way to help ruin your diagnosis as well. Thank you. Okay, some other tests that we need to perform are manual muscle tests. Where I'm going to show you this video that shows how we test for upper trapezius. In the beginning, I'm going to show you how it's really for the levator scapulae. And so in school, we're taught, upper trap was just a shoulder shrug. But now we're seeing that when you shrug your shoulders, the levator scapula is more dominant because your arms are depressed. So your scapula are more likely to be dorsally or rotated. So in order to do the upper trap and isolate that better, you should have your arms above or overhead when shrugging to isolate the upper trapezius better.
Ok, en este video vamos a enseñar prueba muscular manual para los rotadores ascendores, en especial el trapecio superior. Esto es importante hacer con el paciente con los brazos hacia arriba. Y luego la prueba muscular manual para rotadores inferiores, que es el elevador de la escápula. Es importante probarlo, hacerlo con los brazos hacia abajo.
The next thing that we're going to do is a manual muscle test for the upper trapezius muscle. It assists with upper rotation of the scapula. So what we were taught in school was to have the patient shrug their shoulders, hold them and push it down. And obviously this guy's very strong, it's not going to break, but the research is now showing that that's not the best way to do a upper trap manual muscle test. So the best one to do right now is to have them go overhead, if they can without pain, right? And then have them shrug their shoulder and try to see if they're having any difficulty maintaining that posture there, okay? And as you can see, that right side is a little bit lower. So I would grade that as a 3- because he's having a hard time getting to gravity. And if they're able to do it with no problem, then I would just shrug the shoulder blades down to see how he responds. But that's how you test it. Okay. All right, so the next one is the lower trapezius. This is another muscle that helps upwardly rotate the scapula. So this muscle is weak. This is something that we want to strengthen. And I'm going to show you how we manual muscle test here at the clinic. It's a very tedious manual muscle test. And so I kind of go in detail on how we like to do it specifically.
Ok, en este video vamos a enseñar prueba muscular manual para rotadores ascendores, trapecio inferior. Es importante con este ayudarle al paciente a ayudarle a sostener la posición antes de dejarlo ir y probar hacia gravedad.
Muscle test, we're going to go over how to do a manual muscle test for the lower trapezius muscle. So you're going to want to have that patient in a Y position. You're going to want them to have their shoulder blade squeezed. Okay, so squeeze that shoulder blade, keep that thumb up. Okay, and I'm assisting him, right, to get that shoulder blade squeezed, but I'm gonna let go and tell him, okay, hold it there. Don't let, try to hold it there. And if I see that shoulder blade just AV duct right away, like it doesn't stay, then that's a 3- for me. I'm not even gonna bother pushing down. But let's say I put him in that position, everything is still, the scapula is not moving, then I'll go ahead and apply the pressure. But he and most patients will not be able to hold this position. Hold it one more time, hold. You can see that shoulder blade drift, which means that he's a 3-. All right, so this also manual muscle test is for the cerase anterior. It's a big muscle to kind of help with that dysfunction. Definitely something we want to strengthen because 9 out of 10 times this muscle is always weak. And we like to check this in sitting. It's a very tedious, you need to really be able to feel with your hands on the inferior border of the angle of the scapula to determine this manual muscle test.
Ok, el video va a enseñar la prueba muscular manual para rotadores ascendores del serrato anterior.
So we're going to go over the cerase anterior, which is a big muscle for upper rotation of the scapula. So the way we test to see if it's weak is we put the patient's forearm over our shoulder. We help assist in upper rotation of the scapula, okay? And we ask them to hold it there in that position. And what I'm doing is I'm feeling for that inferior border. And when I step away, if I feel that inferior border of the scapula kick back against my fingers, that's a 3 minus. Unless we know that the cerase anterior is not strong enough to maintain that upper rotation of the scapula. And that's a 3 minus. If they are able to maintain that position, no issues, then I would apply a little bit of force here. But in your evaluations, most patients will not be able to hold and sustain that position without that shoulder blade wanting to downwardly rotate again. So we're going to go.
Okay, so in the manual muscle test for the rhomboids, the reason I'm showing this video is because these muscles are usually very dominant and strong during someone with insufficient upper rotation syndrome. And so just to kind of help prove a point that when patients have this, they're usually very strong in the rhomboids. And so we'll demonstrate that right here.
Ok, este video va a enseñar la prueba manual muscular para el rotador inferior romboide. Lo importante de esto es que a veces los pacientes con este diagnóstico se presentan con estos músculos muy dominantes.
So we're going to go over a manual muscle test of the rhomboids. Typically, this muscle is very strong and dominant and can cause the scapula to downwardly rotate. And so when people have insufficient upper rotation, sometimes we have to do like soft tissue around that area just to kind of help break some restrictions to help with the upper rotation. But I'm going to go and show you the test just to prove a point that on most patients, you're going to find it very strong. So I'm going to put in a position here, which is like a W position. Okay, I'm going to tell them to squeeze the shoulder blade. Good. I'm going to hold it. I'm going to tell them don't push you forward. And force going from here to there. Bring you. And he's very strong. Can't break him. And that's the wrong. So we're going to.
Okay, now for the fun part. So I want to go over some manual therapy techniques that are really, really beneficial for someone with a scapular dysfunction, and we really want to help improve that upper rotation. In this video, I only show scapulothoracic joint techniques, but just keep in mind that the AC makes up 35 degrees of that 60 degrees, and that sternoclavicular joint makes up that 25 degrees. So it's very important to also mobilize those joints in order to help improve the upper rotation of the scapula as well. But I wanted to show you a scapular technique on this one.
Ok, en este video va a enseñar técnicas de terapia manual, movilización lateral de la escápula. También es importante, deben trabajar en las articulaciones acromioclavicular y esternoclavicular, ya que esos dos ayudan a formar los 60 grados del movimiento.
All right, so this technique, it's a manual therapy technique I'm going to show you is for the scapula, thoracic joint. And what you want to do is if you're treating the right shoulder, your right arm should be supporting that shoulder. Okay. And then you want to make sure that you're not too abducted or too abducted. You kind of want to make sure you're almost like in a scaption type position just to kind of help prevent any pain while doing this technique. You then want to upwardly rotate as you help guide them into flexion and just kind of help improve that scapulothoracic joint. Upwardly rotate the shoulder. Most patients say this feels good. And after you do this, you want to test and retest and check to see if that helped with their mobility If it did, you should add this to your regimen during the rehab process to help improve overhead motions. All right, so this technique.
Okay, so this next technique is also for the cerase anterior. You're in side lying position. Since you already did the scapulothoracic joint, this is a good contract, relax, or an MET for the cerase anterior to improve that upper rotation of the scapula.
Ok, vamos a enseñar en el video técnica de terapia manual, contracción y relajación muscular para el serrato anterior con el paciente también acostado de lado.
There's another technique to help with upper rotation of the scapula. And it's a contract, relax technique of the cerase anterior. Okay, so what you want to do is you want to train the patient how to engage that muscle by rocking your shoulder blade back and forth. So you're going to tell them, I want you to activate and push your scapula towards my hand in this direction. Hold it, and I push you down. Hold, 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 hold. So I'm trying to downward rotate his scapula, and he's trying to resist that. Okay, hold, 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 and relax. And again, hold, 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 hold. And again, hold. Hold, hold, hold. We'll do about 3 sets, 6-second holds for this technique to really help activate the cerase anterior and improve that upper rotation of the scapula. Thank you.
Okay, now for some strengthening exercises that I like to teach my patients. I like to do this in the clinic, and I also like to prescribe this for their home exercise program. And so we want to, really address the upper trapezius, the cerase anterior, and the lower trapezius, because those 3 muscles really help upperly rotate that scapula, as you can see here in this little picture that we have in the PowerPoint. And all these exercises need to be done while avoiding scapular internal rotation. So if you can kind of have them maybe squeeze their shoulder blades just a little bit, just to avoid that internal rotation, that'd be great. And all these exercises need to be done in a pain-free range.
Okay, so this next exercise are Ys on the wall. Okay, so what this patient is going to do is put his shoulder in a Y position, and obviously only do it if they're able to do it without pain. Okay, and get a little bit closer to the wall here. Okay, you want their chin to kind of be tucked in here. All right, and what the muscle that we're trying to activate is the lower trapezius. So instead of, sometimes patients can't activate the lower traps in prone because it's just too much pain for them or whatever. This is a really good modification. They can use their hand and support with the wall, so it's not as much pain. And what we want to do is cue them by saying, okay, what you're going to do is you're going to lift your palm off the wall here, but your fingers are going to stay intact. But the only way I want you to get that palm off the wall is by activating your lower trap here only. So it should not be coming from the wrist muscles here at all. It should just be coming from the lower trap. So then I would just cue them to make sure they're activating the muscles properly. And the patient may not feel a burn right away, or they may, but typically after doing about 10 reps, you should start feeling a little bit of burn, maybe sooner depending on how weak they are. And that would be a good exercise to activate the lower trapezius, which will also help upper rotation of the scapula. So this next exercise are called touchdowns. You're going to want a patient to use a pillow sheet for this one, or it could be a elastic band, whichever. What you want to do is cue them verbally and tactily around the cerase anterior and the upper trap activation for this one. So what you're going to do is have them place their forearms on the wall. You want them to make sure that their feet are not too far out because you don't want them to hyperextend their back. Okay. And then you want them to slowly raise their arms as they're protruding back here with their scapula to kind of help activate that cerase anterior more. So they're gonna go up slowly, the slower the better, okay, to really emphasize the muscles that we're trying to accomplish, which is cerase anterior here. And then once they start going overhead, we want that upper tract to activate as well to help with that scapula upper rotate more. And then slowly down, leading with the elbows down, okay, to help get an eccentric contraction of the cerase anterior. I would recommend doing about 5 reps to start off and working your way up to 10 reps with your patients every time. So this next exercise.
Ok, ese video anterior, los dos videos enseñaron ejercicios para fortalecimiento, para aumentar la fuerza en el trapecio superior. No hagan encogimientos del hombro con los brazos presionados. Para aumentar la fuerza en el trapecio inferior, ese fue el ejercicio Y, hacia la pared, puede ser parado. También para aumentar la fuerza del serratus anterior, que fue con los dos brazos también en la pared. Y todos los ejercicios deben realizarse evitando la rotación interna escapular, entonces pueden apretar hacia atrás.
Okay, so this next movement dysfunction is humeranthroglide and meteor rotation syndrome. So there's a lot of signs and symptoms here. It's very common in athletes who are involved in throwing sports, just like baseball, volleyball, swimming, if they're weightlifters, or moms who like to reach in the back of their car and grab their purse from the back seat, or any position that has a lot of heavy labor. They also have pain in the anterior or posterior glenohumeral joint, as well as pain along the deltoid area. Pain is worse with overhead motions or reaching backwards. Sometimes patients will report that they have like subluxations where they kind of feel like it's popping too much, and you'll see that they'll have excessive anterior motion of the humeral head during shoulder motions. Like you just see them anterior glide that a lot. In that video where I showed you, if you see that the humeral alignment is more than anterior 1/3 of the acromion, that's also another way to check it out. And if they have weak subscapularis, or if they have a stiff posterior glenohumeral joint capsule, and usually they're dominant in the deltoid, the infraspinatus, and the teres minor during external rotation. And they usually have short pecs over the rotator cuff musculature, and the dominance, shortness, and relative stiffness of the humeral internal rotation is more from the pecs and the teres major, more so than subscapularis. So subscapularis is something we want to strengthen.
Ok, entonces el síndrome de adiestramiento anterior y rotación medial es común en atletas deportivos de lanzamiento, voleibol, natación, levantadores de pesas. Las mujeres a veces nos alcanzamos la parte trasera del automóvil para agarrar nuestra bolsa. Trabajadores pesados tienen dolor en la articulación glenohumeral enfrente o a veces atrás. Tiene dolor a lo largo del área deltoide. Es peor con movimientos por encima de la cabeza o alcanzar especialmente hacia atrás. Puede que el paciente sienta que subluxaciones en el hombro. El movimiento anterior de la cabeza humeral es excesivo durante los movimientos del hombro. La cápsula anterior es más flexible cuando el terapeuta está sintiendo que la cápsula posterior y los rotadores externos. La postura es el hombro adelantado y la cabeza humeral está más del 1/3 anterior del acromio anterolateral. La cabeza proximal del húmero anterior al extremo distal del húmero. El húmero puede estar en rotación interna o el hombro hacia adelante. El músculo subescapular alargado. Los músculos acortados, infraespinoso, redondo menor, deltoide posterior. La cápsula posterior está rígida en la articulación glenohumeral. Los músculos deltoides posteriores son más dominantes sobre los músculos infraespinosos y el redondo medor durante la rotación externa. La dominancia o el acortamiento del pectoral mayor sobre la musculatura del manguito rotador y la dominancia o rigidez relativa de la rotación interna humeral más del músculo pectoral, del músculo dorsal ancho y el redondo mayor comparado al subescapular, que es importante.
Okay, so in these videos, I'm going to show you the key tests that we check for AGMR of the shoulder. You want to have the patient in supine to do these tests, and here we go.
Ok, en los videos enseñaremos pruebas claves que pueden hacer en posición supina, a enseñar el rango movimiento pasivo, a la rotación interna normal sin deslizamiento anterior debe ser entre 70 y 80 grados. Pueden realizar pruebas musculares manuales también en esta posición del músculo subescapular.
Okay, so we're going to do some key tests to see if a patient has anterior glide medial rotation syndrome. And so when we do passive range of motion for shoulder internal rotation, normal is 70 to 80 degrees, okay? But what we want to look out for is the humerus here. Does it pop up anterior glide when it's supposed to posterior glide, right? So if I'm starting to see this pop up before they even get there, then that's kind of where I'm measuring their range of motion. I'm not forcing it. Even though they're able to get there, they're not getting there properly, okay? Another way to assess is support the elbow with your hand, put some posterior glide on the forearm, and then watch, then internally rotate, and right there, I'm already feeling a restriction. And obviously that's not 70 degrees, it's like 45 degrees. So that's a one way to determine if a patient has anterior glide medial rotation. Do a manual muscle test of the subscapularis. Typically with patients who have anterior glide medial rotation syndrome of the shoulder, this muscle is very weak. And when this muscle is very weak, it doesn't allow that suction-like properties that this muscle does to help keep the humerus on the glenoid muscle properly. So what I'll do is I'll put my hand on the humeral head and do a posterior glide, okay? And if I notice that this patient is anterior glide because they're horizontal abducting, I'll put maybe a rolled up towel, kind of support to keep that neutral. Do a posterior glide, internally rotate for them. Tell them to hold, only push you back. And if they're having a hard time, then that's a 3+, and I'm able to break them pretty easily. Okay, but with patients with anterior glide syndrome, we want to make sure that this doesn't cause any pain. Okay, you want to just kind of resist gently. The other thing you want to make sure is that you're putting a posterior glide the whole entire time. And if you get to the point where you're not even able to get to the 70 or 80 degrees, and you feel that humeral head pop up into your hand, then you should probably just stay there, hold it, and resist and see how they do as well. And within the available range. Thank you. Yeah, man.
Okay, so this next slide is we're going to do some manual therapy techniques and self techniques that the patient can do at home. That way they don't need us forever to do this for them. It's very important to make sure that we do exercises for patients to do self-care.
Ok, en estos videos vamos a enseñar técnicas de terapia manual de deslizamiento posterior para la articulación glenohumeral. Una es más para tarea para el paciente que puede hacer en casa y el otro es para practicar con el terapeuta en la clínica.
Today, we're going to do or demonstrate a posterior glide that a patient can do on their own with some rope bands. You can come on this angle over here and show how the band is placed in this individual. The band will be on the anterior aspect of their humerus here. And what you want them to do is, if they can, without any pain, kind of reach into internal rotation. And what they can do is have one foot forward from the other and kind of like do a little lunge with that knee to really help mobilize or keep that posterior capsule stretch here. You can have them hold it for about 30 to 60 seconds, or you can have them go back and forth for 30 to 60 seconds as well, just to kind of help push that humeral head back with anybody who demonstrates with the anterior glide syndrome of the humerus. Okay, so we're going to do a manual therapy technique to improve the posterior capsule of the glenohumeral joint. So what you want to do is make sure you get the patient about 55 degrees of shoulder abduction, and then get into about 30 degrees of shoulder horizontal adduction. And once you're there, that'll be an open pack position of the glenohumeral joint to where you can do a glenohumeral joint mobilization in a posterior direction to help improve flexion and internal rotation. Grade 1 and 2 is for pain. Grade 3 and 4 is for range of motion. You can do it that way. You can do it with the body inside the arm here. Same thing. And you can even do it with the patient almost in a Hawkins candy position. Just don't rotate inward, right? Keep it in neutral position and posterior glide like so. That's it. Today.
Okay, this other manual therapy technique is really important because, as we mentioned earlier, pec major is usually very dominant, very short, and that is one of the leading reasons why sometimes our humerus anterior glides. So working on that pec major is very important. This technique is obviously done for someone who is a male. If you're working with a female, I would advise that you have the patient grip their own pec major and you just guide them on how to do the technique. And here is an example.
Ok, vamos a enseñar una técnica de terapia manual para la movilización de los tejidos blandos a lo largo del músculo pectoral mayor. Este músculo se presenta típicamente dominante. Y si están trabajando con una paciente que es una mujer, ella puede ayudar con su otra mano a agarrar el músculo pectoral mayor para que no se sienta inconforme.
This next manual therapy technique is soft tissue mobilization for the pec major. We're going to do one for the deltoid and for the latissimus dorsi. Okay. So I like this technique just because I feel like it's more effective and it's more of a functional movement pattern for that pec major. So what you want to do is, obviously, on a male, it's fine for areas that are tight, and you can kind of tell by the grimaces on patients' faces, as well as just like trigger points along the muscle belly. And what you want to do is you want to kind of grip on here, and then you can have them actively or passively elevate their arm. And as you come back, you re-grip to a different spot and stretch that pec major by sustaining that grip as you elevate the arm and then releasing as you shorten it to re-grip to a different area or different fibers of the muscle. That's for the pec major.
All right. This next manual therapy technique is for the deltoid. That's a very similar approach that we did for the pec major, just targeting the deltoid on this one. Deltoids are usually very dominant, and so we just kind of make sure that we lengthen it because it's so short.
Ok, este video va a enseñar técnica de terapia manual para la movilización de los tejidos blandos a lo largo de los músculos deltoides, que también igual al otro video se presenta muy dominante.
All right, so I'm going to show you a soft tissue technique of the deltoid. So what I like to do is abduct the patient's shoulder within the pain-free range, shorten it by gripping onto it, and then adducting the humerus while maintaining that grip just to help stretch that deltoid. And it's a great manual therapy technique. Patients usually enjoy this one. Or some say it's like a good hurt sensation. And you gotta just use your body to kind of go back and forth. Use your hips. And just re-grip every time you go into the abduction starting phase. Yep.
This next one is for the lats. This one is typically very tender to palpate. Patients will make grimaces and it will be uncomfortable. So I would definitely let them know beforehand just to get them aware of the technique that you're about to do. But try to also keep in mind that you don't want to cause too much pain when doing this particular treatment. You want to stay in a tolerable pain range with this one.
Ok, en este video va a enseñar técnica de terapia manual para la movilización de los tejidos blandos a lo largo del músculo dorsal ancho. Este músculo, cuando haces puede ser un poquito más sensible para el paciente. Es importante mantenerlo en un rango que no le duela mucho al paciente.
Next one we're going to do is a soft tissue technique for the lats. Okay, so what I like to do is make sure I find the muscle belly here. And you can tell by the grimaces of the patient's face, it usually does not feel comfortable. It's usually a very tender area to work on, but it's a necessary evil. Okay, so I push down onto the muscle belly here. I extend them to neutral, internally rotate their arm, and I externally rotate and flex to where they can in the pain-free range. You can do this passively or you can have them do it actively. And every time they come back down, I re-grip into a different spot, find a different fiber that's tight, and just kind of go back and forth. And what I like about this technique is that, you can work on passive range of motion for overhead motions, as well as stretching the muscle belly and almost doing trigger point therapy all at the same time. So the patients get a bang for their buck here. That's it.
Okay, so the next topic we're going to talk about is strengthening the subscapularis muscle. This is one of the most important muscles to strengthen. You can do it in seated and standing, that's fine. Just make sure that the shoulder blades are squeezed and that they're not rotating inward like this, because that can really defeat the purpose of what we're trying to accomplish, and they can get more of the pecs here. You really want to emphasize the posterior glide. So I usually like for patients to do this in prone. That way the table is posterior gliding for them, and then they just do internal rotation there. But I also like to be hands-on with the patient when doing this one. So supine is typically what I have them do, and I'll demonstrate that in this video right now.
So this is a strengthening exercise for the subscapularis. What I like about this one is that the therapist has always maintained a posterior glide to prevent that anterior glide syndrome. We also want to make sure that a patient is gripping onto the band properly so that they're not going in different directions. You want to make sure that they're going straight into internal rotation like so, nice and clean and slow. If you start to feel their humerus pop up into your hand, that should be the limit wherever it starts to begin, okay? So even if it's just right there, then that's their limit, okay? But just make sure that you don't do this exercise and force it and they're anterior gliding, because then we're not fixing the issue, we're just enabling it, okay? So you got a resistance band for therapist discretion. Therapist does a posterior glide on the humerus, and then we'll just ask the patient to internally rotate. So go ahead and rotate your arm in. And then right there, I start to feel an anterior glide, so that's his limit. And then come back into the starting position. And then go shy of that next time. Okay, so right there and back. Again. This is a good way to strengthen the subscapularis muscle while retraining it to stay in the posterior glide position. Thank you.
Ok, ese video enseñó un ejercicio para el fortalecimiento y aumentar la fuerza en el músculo subescapular, que es el músculo más importante porque crea propiedades de succión para mantener el húmero en la fosa glenoide. Al hacer el ejercicio es importante para el terapeuta enfatizar el deslizamiento posterior de la articulación glenohumeral al hacerlo, y se puede hacer de pie, sentado, pero preferiblemente acostado, como enseñó el ejercicio.
So every time a patient comes to your clinic with shoulder pain, I think it's very important to make sure that you check for thoracic and cervical mobility. We didn't go in depth on it in this presentation. That's definitely a discussion for another time. But I did want to show you guys why it's important to at least assess the thoracic mobility, just because you do need to have adequate thoracic extension in order to achieve full range of motion in the shoulder. So regardless if you have AGMR or insufficient upper rotation syndrome of the scapula, a thoracic mobilization or manipulation will pretty much always be beneficial for the patient for shoulder dysfunctions.
Entonces es muy importante evaluar la movilidad torácica y cervical también, porque juega un papel importante en la mecánica del hombro. Estas regiones deben ser evaluadas en la evaluación por el terapeuta. Para tener un rango completo del movimiento del hombro, debe haber extensión torácica adecuada y, por lo tanto, independientemente de la disfunción del movimiento, una manipulación o movilización torácica sería beneficiosa para el paciente.
Hello. So I didn't mention this in depth in the PowerPoint, but I wanted to make a quick video about how important thoracic spine mobility as well as cervical mobility is when treating the shoulder. I think that is something that's always necessary to be assessed when treating the shoulder. But just for time's sake, we went over just shoulder things. However, in order to achieve full range of motion in the shoulder, the thoracic needs to be able to extend a little bit to achieve that full range of motion. So regardless if it's an AGMR or insufficient upper rotation, a thoracic manipulation on the segments that are stiff from the patient will always be beneficial. So I'm gonna go ahead and show that for you. Go ahead and lay it down on your back, face up. So in this technique, you wanna make sure that you stack the elbows properly. If you notice that some patients kind of horizontally deduct too much and they're hypermobile in their shoulder, what you can do is have them hug a pillow to help them protract the shoulder blades and the T-spine a little bit more to get a better audible cavitation of the thoracic spine. Find the segments that are stiff. You want to lean over, flex down a little bit, and thrust.
Okay, guys, this concludes our presentation for today. I hope you all enjoyed it. Here's our list of references that we used for the PowerPoint today. And I want to thank you all for taking time in your day to hear us out. Any questions?
Ok, ahí tienen las referencias. ¿Alguien tiene preguntas? Muchas gracias.
Well, that was a great elaboration, Sergio and Ms. Martinez. thank you so very much for doing this both in English and Spanish for our people. There are some questions in the chat box. If you can see the chat box over there, please.
Yes.
Yeah. So from there, if you can go from the latest, if you don't mind, there are some questions that people are asking. If you don't mind answering them, and then we can sign off. But that was great. That was great.
Okay. All right. Let me just see what the questions are here. Translation. Okay, sorry guys. Yeah, we did this in English and Spanish, so I am sorry if there was any confusion there. Let's see. How to check for strength of upper arteries if the patient has no / reduced overhead shoulder flexion. I'm not understanding that question. So I'm going to move on here. How much pain aggravation is okay during acute rehab phase? How long does it take to see a noticeable change after impingement syndrome or rotator cuff tendon? Do you incorporate kinetic chain slings in your shoulder rehab exercises? Yes, I do. And honestly, you should see changes immediately with the stuff that we've talked about today. Typically, those are things that you want to see day one. I typically have great and fast results with our patients who come in with shoulder pain. If you don't see any results within the first 2 weeks, then something has to change in the rehab process, or maybe they have to go back to the referring provider and get maybe further imaging to rule out any other pathologies. But if it's truly a mechanical issue, you should see results within the first 2 weeks, most definitely. Soft tissue, STM is soft tissue mobilization. So it's like any massage techniques. Yeah, thank you guys for answering that. Test pruebas claves, key tests, it's just like a little thing to catch on just in our titles, just like, okay, key test to assess. And then it's also Dr. Sergio Martinez. She's my wife. She helped me translate in Spanish today.
Thank you, Ms. Martinez. We really appreciate that.
Please. Okay, yeah, so when we're doing soft tissue mobilization of the deltoid, typically the deltoid is very dominant and short. So when we know that the deltoid is a abductor of the shoulder, so you want to start them in a shortened position. You grip onto the deltoid and then you adduct the shoulder to help stretch and release some of the trigger points of that deltoid.
Thank you, Shweta. The clinic is located in Olmito in Port Isabel, Texas.
All right, guys, you guys are doing great. Guys, please understand to assess and diagnose the problem with the shoulder, or whether it's upper trapezius or rhomboids. So first, assess the problem and then go for the thing, as Dr. Sergio and Miss Rocio, if I pronounce that right. Yeah. So unfortunately, there won't be any quiz and free certificates for our free lectures now. This is mostly for educative purposes. Thank you so much, Dr. Martinez. Thank you so much, Rocio. We hope you enjoy your day ahead. And it was a great presentation and a great hard work. I can see those videos, and Spanish translation was really great. Thank you so much, sir. Appreciate it.
Thank
No problem.
you.
Thank you for
Have a
having
good
us.
day.
Bye-bye.
Bye-bye. You too, sir. Have a good day.